session. If you haven't already joined SHARP, can I strongly encourage you to do so? At the end of the presentation, the last slide will provide you with details on how you can join SHARP, or you can just Google our website and send an email to the SHARP office if you are interested in joining SHARP. It gives you access to webinar series such as this, and also our excellent annual scientific meeting in November this year, which will be held at the Royal College of Surgeons in Edinburgh. We can encourage you to save the date as well. We'll be sending out a save the date email soon to give you more details on the annual scientific meeting. But can I welcome all of you once again to this webinar series. This evening, we are privileged to have Professor Miles Fisher here with us to speak to us on the management of diabetes, and particularly around the modern treatments that are available. As many of you know, there has been an explosion in the options available to treat diabetes, and Miles will take us through that with the evidence base for those treatments. Miles is Honorary Professor at the University of Glasgow. He was for 20 years consultant physician at Glasgow Royal Infirmary before he retired in 2020. Miles is also past vice president, of the Royal College of Physicians and Surgeons in Glasgow. He's past president of the Scottish Society of Physicians, and also previous co-chair of SHARP in 2017. Miles is internationally recognized for his work and his involvement in many of the landmark trials in diabetes. And he's a much sought after speaker. I believe, Miles, you've just come back from the Middle East after speaking there as well. So we are very privileged to have you. He's been involved in guideline developments. He's worked with SIGN, European Society of Cardiology, European Association for the Study of Diabetes, and also NICE. So we are very pleased that you can join us today, Miles, and the floor is over to you to talk to us about the modern treatment of type 2 diabetes. Thanks, Miles.
Thank you very much for that kind introduction. These are my declaration of interests over the last couple of years. Over the last 20 years, I've worked with really all of the manufacturers of drugs which are used to treat people with diabetes. I start with a very dry slide. This is the WHO classification of diabetes, which was...
Could you share your slide? Sorry, could you share your slides with us at the moment? We've got your camera, but not your slides.
Okay, sorry. Now, is that sharing with you?
Yes, it is. Thanks.
Fine. Okay. So these are my declarations. The WHO classification was redone in 2019. Type 1 is the beta cell destruction occurs in youngsters. Type 2 really covers the common forms of diabetes, which are associated with overweight and obesity. Sorry for that. Some patients have a hybrid form where it's not clear whether they're type 1 or type 2, and sometimes just observing the patient over a series of years will make it clear. We shouldn't forget the genetic causes and also pancreatic diabetes. Having worked in the East End of Glasgow for many years, our type 3 diabetes was pancreatic diabetes related to chronic pancreatitis. And then there's also hypoglycemia, which is first detected during pregnancy. Now in Scotland, because of a CHI number and the fact we use a single diabetes database, we have very accurate information about the number of people with diabetes and year-on-year increases. And that's because of changes in lifestyle as the population gets older, as the population gets heavier, and as the population takes less physical activity. Now, this is looking at type 2 diabetes, by far, as I say, the majority, and this is the age distribution. Now, in red here is the age distribution of the Scottish population, and in blue, people with type 2 diabetes. So you see that it still remains a disease of middle-aged and elderly people. The vast bulk fall into this age group. But the worrying feature is down here, that we are seeing type 2 diabetes in small numbers in teenagers, in larger numbers in people in their 20s and 30s, again related to major lifestyle changes with obesity and lack of physical activity. If we look at the glycaemic management in Scotland, this is the HbA1c by Health Board. if we just focus on the end here, only slightly over 50% have an HbA1c less than 58. And you see 20% of an HbA1c greater than 75, or poor glycemic control. Now, contained in that, there may well be elderly people with comorbidities where you're not trying to get tight control. But there still is a large number of people who are in the middle age group who are not to target, and that this represents thousands and thousands of people with diabetes in Scotland. Now, simply, we can divide therapies for diabetes into old drugs and new drugs. And I'll very briefly give a summary on each of the older drugs: metformin, sulfonylureas, pioglitazone and insulin. I won't actually discuss acarbose because although it's been available, it's very rarely used in Scotland because of gastrointestinal side effects. And then in more detail, I'll focus on the newer drugs because we've got more detailed information about them. That's the DPP4 inhibitors, sometimes called gliptins for short, the SGLT2 inhibitors, sometimes called gliflozins, and then the GLP-1 receptor agonists, which are usually something tied, as we will see. Now, SIGN last updated its guidelines on the management of type 2 diabetes in 2017. The older drugs, clearly what they said remains highly relevant. The more recent drugs, things have changed a bit since the SIGN guideline, and I'll come back to that. So this is data extracted, and for each of the classes of drugs, I'll use a similar approach. So SIGN says that metformin is moderately effective, it has some cardiovascular benefit, a low risk of hypoglycemia, it causes slight weight reduction, and the major adverse event is gastrointestinal. And approximately 1 in 10 people cannot take metformin because of gastrointestinal side effects. It accumulates in CKD, so dosage reduction is required in various degrees of CKD, and at some point your eGFR will fall below a level where it's safe to use. And metformin, SIGN recommends, should be considered as first-line oral treatment option for people with type 2 diabetes. And that remains the approach in most international guidelines on the management of type 2 diabetes, that metformin is the first-line therapy. Now, the cardiovascular benefit is a small subgroup from the trial called UKPDS, which had several centres in Scotland took part in this. The metformin group was added slightly later. It was a smaller subgroup, and it was that subgroup, surprisingly to the investigators, that seemed to do the best. So any diabetes-related endpoint was reduced, diabetes deaths were reduced, all-cause mortality and myocardial infarction. Now, this trial was not done to the standard of modern cardiovascular outcome trials, and this really remains the only evidence for metformin. But nevertheless, it's based on this and the fact that metformin is an inexpensive and generic therapy that metformin is first in most guidelines. Sulfonylureas are almost as old as metformin. They have a higher efficacy, they have no cardiovascular benefit, and they have a high risk of hypoglycemia, which limits their use in patients. If a patient has a hyposulfonylureas, they don't like it. It also causes weight gain, and again, patients don't like weight gain. So the major adverse events are hypoglycemia, and as all of the currently available sulfonylureas are excreted in the kidney, then careful monitoring and dosage reduction is required as your eGFR worsens. There used to be a class of drugs, thiolazine diones. There's only one left, it's pioglitazone. It's moderately effective. It's probably not as strong as sulfonylureas. It probably reduces atherosclerotic events, as I'll show you in the next slide, but it causes fluid retention, so it's contraindicated in heart failure. It has a low risk of hypoglycemia, but it causes major weight gain, and that is fat as well as fluid retention. So patients don't like pioglitazone because of these side effects, and has been identified, particularly in a Scottish data set, edema and fractures are a major side effect. It's not renally excreted, so it can be used in an unchanged dose in people with CKD. So this was a trial called PROACTIVE that we took part in Glasgow Royal Infirmary. A controversial trial at the time. The main outcome included peripheral vascular events, but the secondary endpoint was the kind of thing very similar to the modern trials. It was all-cause mortality, non-fatal myocardial infarction, and stroke. And it was significantly reduced. And this was a double-blind, placebo-controlled trial. And I say data from the Scottish Diabetes Database, Scottish Diabetes Research Network Group epidemiology group showed that rosiglitazone and pioglitazone were associated with hospitalization for hip fractures in men and women. And so it's for this reason particularly that pioglitazone has fallen out of favour. Now, insulin, of course, is the oldest of the therapies. Insulin has been available for just over 100 years. And it's 100 years next March that it was first used in Glasgow Royal Infirmary. And of course, it was used particularly for type 1 diabetes, and it remains used in type 1 diabetes, but it still has a place in type 2. It's highly efficacious. It has no cardiovascular benefits, a very high risk of hypoglycemia, and it causes marked weight gain. So it's quite similar to sulfonylurea, is potent, risk of hypoglycemia, and causes weight gain. Now, it can be used in renal disease. As the renal disease worsens, the dose of insulin gets reduced. And then if people go into end-stage renal replacement therapy, you often need a massive increase in the dose of insulin. And many of our patients out in the community with type 2 diabetes are on insulin. Many of them now are on a combination of insulin and some of the modern treatments. Just a slight aside here. We are all familiar with insulin pens and the use of pen devices for injections. I just want to remind you that this was an invention from the Southern General in Glasgow by John Ireland and Sheila Reith, who was working there at the time. It was an alternative to disposable syringes or glass syringes, and it was then developed further by, first of all, Novo Nordisk into the very modern pens that we're familiar with nowadays. So this was actually invented in Scotland. Now, these older therapies, metformin, sulfonylureas, and insulin, have been combined together in a series of trials which looked at intensive treatment of diabetes versus less intensive, all open label trials. So not, again, say the kind of design of the modern trials. In all of the trials, there was reductions in microalbuminuria outcomes, but in none of the trials during the course of the trial was there a reduction in cardiovascular disease. The UGDP was a very old trial from the 1970s and showed an increased mortality in some subgroups. And the same was seen in Accord, one of the more recent American trials. But if you put together the data from the 4 more recent ones and look at particular outcomes, there is a statistically significant reduction in myocardial infarction. So intensive therapy does have a slight effect on reducing myocardial infarction, a slight effect on overall cardiovascular events, no effect on cardiovascular mortality. So glycaemic interventions per se are not as good at reducing large vessel disease as, say, blood pressure treatment or treatment with cholesterol-lowering agents such as statins. Now, fortunately, in diabetes, we're quite patient. We've had to be to get good results in our trials. And so there's been long-term follow-up on many of these trials. And in particular, the UK PDS trial was followed for another 20 years. And if you do that, you see significant reductions in cardiovascular disease and overall mortality. So again, emphasising that glycaemic control based on the older therapies is of a minor benefit in reducing macrovascular events. Now, SIGN pulled this together, and most guidelines, in fact, all guidelines, base their target HbA1c on the HbA1cs that were reached during these trials. So the target for SIGN is 7%, 53 millimoles, but it says particularly you need to take account the risks of hypoglycemia and weight gain. And of course, as we'll see, modern treatments do not carry the same risk of hypoglycemia, and some of them actually cause weight loss. Now, why do we have so much information about cardiovascular outcomes for modern therapies? Well, it goes back to rosiglitazone, which was the other thiolazine-dione that was available for a reasonable length of time for clinical use. A meta-analysis of data suggested an increase in myocardial infarction and a non-significant increase in cardiovascular death. This changed the way that drugs were licensed in America by the FDA and in Europe. So instead of simply showing that a drug worked over, say, 26 weeks, as was done before, a much more detailed cardiovascular safety program was required. Any events in the phase 3 development had to be adjudicated, and at some point, this included the performance of a dedicated randomized controlled cardiovascular outcome trial. The other thing is these trials and the phase 3 development program used a much higher risk population than had previously been used. So it included the elderly, patients with existing cardiovascular disease, and patients with CKD. So much more representative of the full population of people with diabetes and not just the fit, well-controlled middle-aged group. Now, there are many trials which have now been completed. This slide stops at 2020, and there's more followed since then. But the great thing is that in each of the drug classes, there's been a steady increase in the available information. So as a new trial has come, we've been able to compare it and contrast it to information we have from prior trials. So first of all, let's think about the DPP-4 inhibitors. As we absorb nutrients from the stomach, two peptides are released, GLP-1 and GIP. GLP-1 stimulates the beta cells to increase glucose uptake by stimulating the release of insulin. Now, this is a glucose-dependent peptide, so as the glucose starts to fall, this is switched off. Now, this response is obtunded in people with diabetes. Natural GLP-1 is degraded by DPP-4. So the class of DPP-4 inhibitors do what they say in the proverbial tin. They inhibit DPP-4. The GLP-1 that's released in people with diabetes is around for longer, stimulates more insulin, and also suppresses glucagon. So the combination of these two things lowers your blood glucose. We have 5 DPP-4 inhibitors. They're not all the same. 4 of the 5 are renally excreted. So if your CKD gets worse, or if you have CKD or worsening renal function, dose reductions are required. Linagliptin is biliary excreted, so it requires no dose reduction in CKD. Vildagliptin has to be given twice daily, requires liver monitoring, and also actually has no cardiovascular outcome trial. So in routine clinical practice, what tends to happen is prescribers have one DPP-4 that they use if renal function is normal, and one in the use with CKD. Now, this table just summarizes the cardiovascular outcome trials with the DPP-4 inhibitors. Now, because rosiglitazone was thought to increase atherosclerotic events, the primary outcome in these trials has been MACE, major adverse cardiovascular events, a composite of cardiovascular death, non-fatal MI, and non-fatal stroke. There's 3 trials, one each with saxagliptin, alogliptin, and sitagliptin. And rather unusually with linagliptin, there are 2, one against placebo and one against an active comparator, one of the modern sulfonylureas called glimepiride. Now, in all of these trials, DPP-4 inhibitors were non-inferior for MACE, so it showed they were safe. There was no increase, as had been suggested with rosiglitazone, but importantly, there was no benefit. And then the other information you get from large trials like this is side effects, some of which, as we'll see, are unexpected. So in the trial of saxagliptin, there was an increase in hospitalization for heart failure, and that also occurred in a subgroup in the trial with alogliptin. The other thing is there was quite a detailed look at how these drugs might affect kidney and renal function, and overall there were pretty minimal effects on reducing albuminuria, with no effect on eGFR. Now, this is the trial with saxagliptin, and you see that 3.5% of subjects in the saxa group had a heart failure hospitalization versus 2.8 in the placebo group. So highly statistically significant. The explanation is uncertain. There's lots of suggestions as to why, but research into this area was largely abandoned once the results of SGLT2 inhibitor trials became available, because then people were much more interested in what the mechanisms of benefit of SGLT2 inhibitors might be. Now, from 2017, Sign didn't have too much to say about DPP-4 inhibitors. They're low to moderately effective, no CV benefit, low risk of hypoglycemia, they are weight neutral, there are few adverse events, so they're relatively easy to take, and I've touched on the dosage reduction required for some in CKD. So the rather anodyne statement is they should be considered usually as dual or triple therapy for lowering HbA1c. Now, at this point in time, we know that DPP-4 inhibitors in Scotland are widely used. They are now common as second-line therapy after metformin. So those of you in practice, I suggest that you go back tomorrow and start to audit the patients who are on DPP-4 inhibitors and see if they might not be better on an SGLT2 inhibitor or a GLP-1 receptor agonist, especially if they've got any hint of cardiovascular disease. And going forward, the usage of these drugs will reduce, and they'll tend, I think, to be used in older patients, frailer patients, where you're perhaps not going for the potency of a SGLT2 inhibitor or a GLP-1 receptor agonist, and where the patient has got a limited expectation of life, and so the fact that they don't have any cardiovascular benefit is of less importance. Now, the SGLT2 inhibitors, I think we can happily say, are the wonder drug of the era. They initiated as a treatment for diabetes. They are now widely used in heart failure and CKD. Now, in the kidneys, we all filter glucose. In a non-diabetic person, it's all reabsorbed. In a diabetic person, some of it's reabsorbed and some of it's excreted. And this drug inhibits that process so that glucose and sodium are increased in the filtrate. Now, the glycosuria, which is increased, leads to drops in blood glucose and drops in body weight. And it's probably, simplistically put, the overall handling of glucose is what gives its cardiac and renal benefits. Now, remember, Sign was produced in 2017 when we were in the middle of the series of outcome trials with this class of drugs. So Sign said they were moderately effective. Specific agents had CV benefit, the two that were available at the time, a low risk of hypoglycemia, a loss of weight, which patients very much enjoy. The major side effect is genital mycotic thrush. And at that point, because of lack of efficacy in CKD, it was said not to initiate them. And so Sign particularly targeted the use of these drugs in patients with established cardiovascular disease. And at that point, it was empagliflozin and canagliflozin. Now, I'm just going to remind you about the game changer that was a trial with empagliflozin called EMPA-REG outcome. Empagliflozin was the third drug to class, but the first one, third drug in class rather to market, but the first one with an outcome trial. So top left is MACE, non-inferiority clearly shown, and then superiority is demonstrated. So that for the first time in one of these diabetes outcome trials, superiority is shown. If you look at the composites, it was particularly a reduction in cardiovascular death. And as cardiovascular death is often a cause of death in people with diabetes, that translated into the secondary outcome of all-cause mortality being significantly reduced. And then finally, the icing on the cake with the EMPA-REG outcome was an early and statistically significant reduction in hospitalization for heart failure. Now, if we look at the other outcome trials, again looking for unexpected adverse events, the Canvas program was two trials that were combined for canagliflozin, and in them there was a significant increase in amputations and in fractures. That has not been seen in any of the other SGLT2 inhibitor outcome trials. So if we summarize the diabetes trials, empagliflozin showed MACE superiority, reducing mortality and reduced heart failure hospitalization. Canagliflozin was again MACE superior, showed reduced hospitalization for heart failure, but there's unexpected side effects. Dapagliflozin by then had a slightly different approach. So their trial had two outcomes. One was a heart failure one, combination of cardiovascular death and heart failure hospitalization, which was superior. And as an individual component, heart failure was reduced. Overall, MACE was not significantly reduced, but that's because this trial included people with and without atherosclerosis. And if you look at patients with a prior MI, again, highly significant reductions in MACE were observed. The outlier is ertugliflozin, the most recently available drug, because in that trial, it was non-inferior, but not a hint of superiority for MACE. And only the outcome of hospitalization for heart failure was reduced. So this might be a class effect for reducing HbA1c because the benefits in HbA1c were all the same, but it's not a class effect for reducing MACE because ertugliflozin doesn't do that. If we now focus on the renal outcomes, just to remind you, and this is data from MPREG outcome, there were two doses, 10 and 25 milligrams. In type 2 diabetes, your eGFR slowly but steadily declines because of diabetic kidney disease. With SGLT2 inhibitors, you see an initial slight fall, and then it stabilizes out. So if we look at the outcomes in each of these trials, there was a renal composite outcome, combinations of different degrees of worsening eGFR, development of end-stage renal disease, and then either death from renal disease or cardiac causes. And in the empagliflozin, canagliflozin, dapagliflozin, their chosen renal outcome was highly significantly reduced. With ertugliflozin, their chosen outcome was in fact not reduced, although when they reanalyzed it using one of the other composite outcomes, this was reduced. So again, ertugliflozin sits differently from the other three, and the other three are now showing evidence of macrovascular benefit, atherosclerotic benefit if you've got prior atherosclerosis, heart failure benefit, and CKD benefit. Now, the cardiologists and renal physicians have been quick, I would suggest, to note these things and then to properly do dedicated outcome trials. So SGLT2 inhibitors are no longer the domain of diabetologists alone, and these are now clearly both cardiac drugs and renal drugs. And I'm just going to give you a snapshot of that because today we're focusing on the diabetes side of things. So DAPA-CKD was a trial with dapagliflozin in patients with CKD. The primary composite outcome was highly significantly reduced, and the important thing about that trial was roughly half the patients had diabetes and half didn't. So CKD benefit regardless of whether you have diabetes or not. Because that in turn speaks to the fact that the benefit has nothing to do with HbA1c reduction, because in non-diabetic subjects there was none. Now there's a very similar trial with empagliflozin called EMPA-Kidney. The top line of that has just been released as a press release. It's also strongly positive, and results will be presented at meetings later in the year. Similarly, in patients with heart failure, dedicated trials have been done. This was the first DAPA-HF, dapagliflozin placebo, composite heart failure outcome, highly significantly reduced. Again, roughly half with diabetes, half with not, and again, the benefit the same whether you have diabetes or not. Since then, we've had published trials with empagliflozin in patients with heart failure, reduced ejection fraction, then heart failure with preserved ejection fraction, and now the dapagliflozin trial in preserved ejection fraction called DELIVER. Top line again, press release shows that this is significantly reduced. So dapagliflozin and empagliflozin are used and will be used in the future for patients with heart failure, regardless of whether it's preserved ejection fraction or reduced ejection fraction. Now, current licensing of SGLT2 inhibitors is different for the different drugs. Dapagliflozin is approved for type 2 diabetes, chronic kidney disease, symptomatic chronic heart failure with reduced ejection fraction, and no doubt in the fullness of time, once the license has been approved, it will also get for all heart failure. As an aside, the 5 mg dose used to be approved for the treatment of type 1 diabetes, but AstraZeneca decided not to renew that license, and so that no longer is available as a licensed indication. Canagliflozin is only available as a treatment for diabetes and for diabetic kidney disease. Empagliflozin has the treatment for diabetes for both forms of heart failure, and again in the fullness of time we'll have it for CKD, and then ertugliflozin is only approved for type 2 diabetes. Now in clinical practice, most of us find it difficult to remember all the doses. So going forward, I think what's going to happen is prescribing will consolidate around dapagliflozin and empagliflozin, because these will be indicated for all the important indications. And there can be no real reason that I can see for using either ertugliflozin or canagliflozin. Now, the final class of drugs are the GLP-1 receptor agonists. Now, these are like a super strong version of DPP-4 inhibitors. So the GLP-1 receptor is stimulated in the pancreas, releasing insulin, suppressing glucagon, and they drop blood glucose, but they also suppress appetite in the brain and delay gastric emptying. And this effect on the brain is a strong one, and it's probably that means the fact this class of drugs is much more potent than DPP-4 inhibitors, and also significantly reduces weight. And some of the drugs in the class have a license in non-diabetic people for the treatment of overweight and obesity. They also have effects in the liver and in muscle and fat, and it's uncertain right now still if these are direct effects or if these are secondary effects to the other effects, including weight reduction. Now, the GLP-1s are a complex group of peptides. They fall into two groups based on structure. Exenatide was the first one available, and you'll remember the interesting story at the time about this so-called Gila monster, this reptile that was found in the Arizona desert, where its saliva was found to have enough amino acid similarity to native GLP-1 that stimulated GLP-1 receptors, but it was different enough that it was slightly resistant to DPP-4. Well, exenatide and lixisenatide are related to that, the Gila monster, whereas the other available drugs like liraglutide, dulaglutide, semaglutide are much more true analogues of native GLP-1, as was albiglutide, which is a GLP-1 that was clinically available for a while, but then withdrawn for entirely commercial reasons. Now, from a clinical use point of view, there's the daily ones, which are exenatide, which in fact is given twice daily, liraglutide, which is a potent once daily, and lixisenatide, which is a less potent once daily. There's the weekly injections, exenatide once weekly, dulaglutide and semaglutide. And then very recently, using interesting technology, we have an oral formulation of semaglutide. About 1% of the total administered drug is absorbed, the other 99% degraded in the gastrointestinal tract, and that also has to be given daily to keep topping up the dose. Now, science says these are highly efficacious drugs, and they are in head-to-head. There are cardiovascular benefits from specific agents, and the number of agents, as I'll show you, is much greater than when Sign came out. A low risk of hypoglycemia, unless you add them to SUs or unless you add them to insulin. They cause weight loss. The major side effects are gastrointestinal, and again, about 1 in 10 people cannot take it because of major side effects, which are either the major ones being vomiting or diarrhea, and those unchanged in CKD. Now, just like SGLT2 inhibitors, at the time, science suggested focusing on people who've got cardiovascular disease for the use of these drugs, and that is now clearly out of date. So some of the trials have been positive and some haven't. So liraglutide with LEADER showed MACE superiority, reduction in cardiovascular death, total mortality, no effect on heart failure. Semaglutide, the once weekly, its trial was again MACE superior. This time it was strokes rather than cardiovascular death, again heart failure neutrality, but unexpectedly retinopathy was increased. Now, that was thought possibly due to the fact that semaglutide once weekly is a very potent reduction in HbA1c, and we know that in some subjects that can temporarily worsen your retinopathy. So right now, we would not recommend using semaglutide in anyone who's got active retinopathy. Albiglutide was a positive outcome trial, but it's no longer available. And then dulaglutide, its trial was MACE superior, reduced strokes. The important thing about it was roughly half the subjects were cardiovascular risk, and roughly half had existing vascular disease. In fact, slightly more than half had cardiovascular risk. So it's this trial and data from others that makes the SIGN guideline out of date, because there clearly is benefit in people beyond those who've got established atherosclerosis. Now, in the trials, albuminuria was reduced, but there was no reduction in, say, in heart failure, and there was no reduction in EGFR. So a pattern of benefit that's different to the SGLT2 inhibitors. Now, this is a complicated slide, and I'm not going to go through it line by line, but just to say, the SIGN guideline then comes up with this algorithm, which is typical of diabetes guidelines. So you start with metformin. It offers a sulfonylurea as an option, but then in small print, others can be used for the 10% of people that don't tolerate metformin. Thereafter, you're looking at your target. If you don't reach target, you then can consider SU, SGLT2 inhibitor, DPP4 inhibitor, or pioglitazone. And of course, emphasizing again, it particularly was those with atherosclerosis where an SGLT2 inhibitor would be used. GLP-1 receptor agonists were only introduced as a third-line agent. Now, this is the updated SIGN guideline, NICE guideline from February of this year. Now, I'm not a great fan of NICE guidelines, but I have to say this is much better than the one from before, which was 2015. And I'm going to show you it because it brings out themes that are starting to happen in diabetes guidelines. So it again suggests first line, you assess HbA1c, cardiovascular risk and kidney function. And if you're not at high risk, you go for the down the metformin. And then you think about an SGLT2 inhibitor if metformin is contraindicated, but say very much first line metformin. If, however, you've got heart failure or established atherosclerotic disease, or you're at high risk of vascular disease, it says start metformin, and then once you've demonstrated metformin tolerability, add in an SGLT2 inhibitor. And that's independent of HbA1c. So in the person that meets these two criteria, you're going to give them 2 lots of therapy. Only then, if you're not reaching your target, do you then add in other therapies. And similarly, this is the second line. So you're already on first line therapy, choosing further ones. Again, you're assessing cardiovascular risk, cardiovascular status, and what the person's already on. And so it says here, consider switching or adding an SGLT2 inhibitor. And then it's only down here that GLP-1 receptor agonists are added. So this bit of the NICE guideline I don't like. I think there is good evidence for GLP-1 receptor agonists in people with atherosclerosis and at high risk. And the only reason they're doing this is to try and limit costs. This is a decision based on cost and nothing to do with efficacy. So if we then start to think about the patient phenotype, if you've got diabetic kidney disease, you want to stop metformin, most guidelines would say less than 30. We do occasionally use it, lower EGFR, caution with SUs because of the risk of hypoglycemia. Pioglitazone can be used, but seldom is. Linagliptin doesn't require a dose reduction. The other gliptins do. Just again to emphasize that in terms of reducing HbA1c, SGLT2 inhibitors will be less effective, but 2 of them now, dapagliflozin and empagliflozin, are renal protective. So you may wish to give them for that effect and settle on the fact that HbA1c reduction is not quite as strong. For the heart failure patient, metformin seems to be safe, except during an acute episode of heart failure when you would temporarily withhold it. Pioglitazone clearly contraindicated, as are some of the DPP4 inhibitors, saxagliptin, and alogliptin. And now SGLT2 inhibitors are a clear part of the treatment pathway for all heart failure patients, those with and without diabetes. In liver disease, we actually have much less information because very few drugs are trialled in advanced liver disease. There's some information in pioglitazone that it might reduce steatosis in patients with NASH. It might reduce the progression of that, but so far the data is not overwhelmingly conclusive. Vildagliptin is rarely used anyway, but if you're going to use it, you need to monitor the LFTs. And rather unusually, based on a small amount of data, if you were to consider dapagliflozin in patients with severe hepatic impairment, the starting dose is 5 milligrams before you increase the standard dose in diabetes, heart failure, and CKD, which is 10 milligrams. So what then are the likelihood consequences going to be after these trials? Well, metformin still seems firmly embedded as first line or first line and combined with other drugs, so metformin will not change in the short term. SUs will fall from favour because they have no cardiovascular benefit, they cause hypos, and they cause weight gain, which patients don't like. Similarly, pioglitazone usage will fall because of fluid retention and weight gain. Insulin usage will go down because once you've exhausted tablet treatments, then you now can consider GLP-1 receptor agonists, where insulin would have been the only option in the past. DPP-4 inhibitors by now should have reached a peak because they have no cardiac benefits. So I'd repeat, when you go back to your practices, look and see who's on a DPP-4 inhibitor and see if they would not be better on an SGLT2 inhibitor. GLP-1 receptor agonists usage should increase, especially now that there's an oral formulation, because we can't say, well, patients don't like injections, because if patients truly don't like infections, use the oral formulation. And then SGLT2 inhibitors, clearly usage could and should increase, not just in people with diabetes, but in people with heart failure and patients with CKD. Now, if you're looking for any further information, along with colleagues in Glasgow Royal Infirmary, edited by 3 of us, but chapters contributed by everyone in the department, we've produced a book with John Wiley called Diabetes Drug Notes, a similar approach to that we've had for non-diabetic drugs in the Practical Diabetes Journal, but this time it's all of the classes of drugs I've covered today, detailed chapters about the different types of insulin, includes actually a chapter on acarbose if you're interested. So this will be hitting the bookstalls at the end of July. So thank you for attention. And then just to remind you, this is information about SHARP. Membership is free, so why don't you scan and join SHARP today? Thank you for attention.
Thank you very much, Miles, for that very comprehensive review of medications for diabetes. Can I just remind attendees that if you've got a question to ask, please raise your hand and turn your camera on and ask them. But in the meanwhile, Miles, there are already a number of questions in the chat. Alice, Alice, I'm not sure if you want to ask the question yourself or if you are happy for me to read that question out on your behalf. Alice asked, her local formulary advises not to use GLP-1 in patients with BMI of less than 30. And is there any research to support this?
No, none at all. So this is one of the bits of the NICE guideline I just don't like. The NICE guideline tried to limit GLP-1s on cost. So they factored in at the end of 6 months, if your HbA1c's not dropped by 1% in old money, or your BMI by 5%, you withdraw that therapy rather than taking a clinical decision. So, and you're only to initiate it in people with a higher BMI, but many patients with a lower BMI, especially ethnic minority patients, because of course you can be obese with a BMI of 29 if you're in an ethnic minority population, these drugs work in patients with a lower BMI. Now, what I would say is maybe if you've got BMI of 25, these are not the class of drugs to go for straight away because you perhaps don't want somebody with that BMI losing a considerable amount of weight. But you can clearly use them in the BMIs 27, 28, 29, and they will be effective in getting down your HbA1c.
Thanks, Mark. There's the follow-up question from Alice as well. She's had a few older ladies who have suffered with vaginal irritation with EMPA recently and wondered if you had any advice on how to manage this to ideally keep them on the medication, or whether other SGLT2s have less of this particular side
That's a very good question. Now, I have now finished clinical practice, but until a few months ago, or in clinical practice, when I initiated an SGLT2 inhibitor, I always warned the patient about thrush. And in the trials, most patients had one episode of thrush, which responded to conventional anti-thrush medications, whether topical or oral ones. Now, there are some patients who get recurrent thrush, and with them, you need to have a conversation with the patient. Because I certainly had patients who had lost enough weight that they wished to continue with the SGLT2 inhibitor because of their weight loss, and they were willing to put up with the thrush. So you need to involve the patient with the decision making and see what they want. But the thrush, if they've had 2 episodes, they're likely to have further episodes. And it will not change if they go to a different SGLT2 inhibitor. That is a side effect, which is a class effect.
That's great. Thanks, Miles. Yeah, I did actually have, there's one lady in particular who's had multiple episodes, and we had that frank conversation, but she just couldn't put up with the side effects anymore. So we're actually considering GLP-1 for her.
Yeah, that's exactly what it is. The other thing to say, it's a lesser side effect, didn't highlight it, but there are some people who do have a sensation of having to go to the toilet more often to pass urine.
Yeah.
In my impression, it was men more than others. And some of them, maybe in the background of, incipient prostatism, some of them, even when they lost weight, they didn't want to keep going with the therapy. So, listen to your patient and involve the patient in the discussion. There's no point in ignoring the patient, because if you just say, no, this is a great drug, it's going to stop you having a heart attack, they're not going to take it. So
yeah, thanks so much. And the BMI, that's really interesting, because I had quite a lot of patients recently that are kind of 28, 29, and it's really put me off because I couldn't find anything in the BNF or the EMC or anything about BMI. It was just in the formulary, so I thought it must be cost related. But it's quite frustrating because you think, oh, this would be perfect for them. So yeah, it's a case of making that decision yourself, isn't it? So
yeah. No, the benefits clearly there. Yeah.
Thank you.
Thanks, Alice. John Clellan, you've got your hands raised. You've also got a number of questions in the chat. John, I'll leave you to ask those questions. Thanks.
Yeah. Well, first of all, I'd like to congratulate Miles for a fantastic talk. I think that was one of the most lucid talks on diabetes that I've ever attended. So thank you very much indeed. And I remember the good old days when you were looking at diabetic cardiomyopathy. We worked together initially. Yeah. But I haven't hung my coat up quite yet. So anyway, great lecture. So what was striking, omission perhaps, but for a reason in the lecture, was talk about the impact of these treatments on microvascular disease. Now, I know there's a little bit of evidence of reduction in proteinuria, perhaps with the sulfonylureas, and of course it may be that the renal benefits are microvascular related, but they might well be related to something else other than microvascular disease. What's the evidence of an improvement, say, in retinopathy with any of these agents?
Okay. That's quite a complex question. The outcome trials, these old ones I touched on in the middle of the talk, UK PDS and things, they demonstrated early benefits in microvascular endpoints, retinopathy, nephropathy, and neuropathy. And that fits with epidemiology. So controlling hyperglycemia per se improves those outcomes. Now, the newer therapies, it's assumed that they will have the same microvascular benefit, but they haven't really been studied for long enough for eye disease or for neuropathy. And of course, one trial was an outlier for eye disease, and that was the semaglutide SUSTAIN 6 trial, where there was an increase. One explanation for that was it's such a potent drug at dropping your HbA1c, and in the DCCT trial in type 1 diabetes, we saw something similar. So there is a semaglutide dedicated retinopathy trial called FOCUS, and that's up and running, and it'll be a few years before we get that. With regards to renal benefits, if you look at it, and DPP4s do have some effect on renal inflammation and tubules and stuff, the best you can say is a pretty minimal effect on albuminuria and no effect on EGFR, so more harder outcomes for DPP4 inhibitors. GLP-1 receptor agonists seem to have a better effect on proteinuria than DPP4s, but again, no overall effect on EGFR. And but you assume that their glucose lowering effects will have the same as, say, metformin's glucose lowering effects or SUs would be. Again, a dedicated trial with semaglutide looking at renal patients. So having put the hypothesis that there might be renal benefits beyond just albuminuria, there is a trial with semaglutide. There was talk of there being one with dulaglutide, but I don't think that's come to pass. So it's been explored, but we don't have the trials completed. And then, of course, SGLT2 inhibitors tick all the boxes, but not retinopathy. There's not a retinopathy trial with SGLT2 inhibitors.
I thought there was some problem with pioglitazone and macular disease.
Yes, pioglitazone is thought to increase maculopathy. It changes where your fat is deposited. So what it does, it deposits fat in your subcutaneous. And we used to have this bizarre conversations with patients. Well, you're putting on weight and you're getting fat around your belly, but it's subcutaneous fat, which is good for you, and not intra-abdominal fat, which is bad for you. But it also puts down fat in your fat cells in your retina. So that's not good for your eyes as well, yeah. So I didn't go in detail in pioglitazone. I didn't go through all the side effects. I was really using the sign data to highlight what they were saying for all the older drugs. But you're right, pioglitazone is not good for your eyes, yeah.
And can you give us an update on aspirin?
Yeah, don't use it unless you've got. Well, I agree with you, to be honest. No, but I don't think. Don't use it unless you've got established atherosclerotic disease, and probably only within a short period of time in acute.
I know it's common practice, but the evidence runs out 4 to 6 weeks after.
Well, no, I was just about to say that.
It's one of those zombie dogmas that
John, I agree with you.
Community has.
Yeah, and in the last iteration, 2010 sign guideline, we said don't use it other than in people with atherosclerotic disease, and we looked to people like you to tell us how long you would use it for. But again, if people are looking for an audit to do apart from patients in DPP4, go back to the practice, see who's got diabetes and on an aspirin, and if they've not had a recent cardiovascular event, do they need to be on it at all? And the answer in many cases will be no.
And of course, the patients on aspirin are very often on PPIs, and we're increasingly worried about the toxicity of PPI.
Exactly. So you can be stopping 2 drugs. Yeah. No, I agree completely. Today's talk was entirely focused on the diabetes drugs and not on other aspects of cardiovascular risk reduction, like aspirin, antiplatelets, blood pressure, cholesterol, and smoking cessation, which are I often put in as a slide at the end. Yeah. So, yeah.
Thank you very much.
Thanks, John. Miles, there's a question from Manish about data around management of these oral agents perioperatively. Is there an optimal duration of withholding these drugs perioperatively? Local practice is to withhold a SGLT2 inhibitor for 10 days pre-op and metformin on the day of surgery.
Yeah, that seems reasonable. There's limited data. There are some expert opinions on it. I would suggest in modern practice of diabetes, and we did this in Glasgow, you need to have a joined up perioperative protocol, jointly agreed between diabetologists and anaesthetists, and then stick to it so that everyone's doing the same thing regardless of which side they're coming from. So, 10 days and 1 day seems reasonable, but I would say if you've not already done it, it needs to be a discussion between anaesthetists and diabetologists, and then on the intranet so everyone can do the same thing, avoiding confusion. It'd be nice if it was the same for the whole of Scotland, because of course junior doctors move from one health board to the other, and if it's slightly different it can cause confusion. But yeah, agree it and then stick to it. Yeah.
Okay, Miles, and there's 2 questions here which is quite topical about the DKA risk with SGLT2 inhibitors. Do you want to comment on that?
Okay, fine, good, yeah. Well, DKA is a common thing in people with type 1 diabetes. is much less common in type 2 diabetes, but does occur. It occurs in the person with type 2 diabetes who's got long-standing diabetes, whose beta cells are exhausted, and usually are already on large doses of insulin. Now, in the trials, all the outcome trials and efficacy trials, diabetic ketoacidosis was increased. It was approximately doubled if you're on an SGLT2 inhibitor. Now, turning that into clinical practice, there are some patients with type 2 diabetes you might want to avoid SGLT2 inhibitors in. For example, a very thin person who's got diabetes for a long period of time and has been on insulin for a long period of time, especially if they've got high HbA1c. There's another group of patients, perhaps on insulin already for a long time, who you might want to make sure they're doing ketone testing. And at times of illness, particularly doing ketone testing to detect ketoacidosis early. For the majority of patients, they don't require specific education on the risk of ketoacidosis, but they do need education on sick day rules, and of course in diabetes, there are lots of drugs fall into that. So if you're unwell, significantly unwell, stop your SGLT2 inhibitor, stop your metformin, stop your ACE or your ARB, stop your non-steroidal. So it's a group of drugs, and SGLT2 inhibitors can sit among them.
Great, thank you, Miles. There's been data that we previously used to assume that tight glycemic control was there to prevent macrovascular disease. But there's data now, isn't there, that if you have tight glycemic control, you eventually reduce macrovascular disease as well. There might be a lag of a few years.
Yes, legacy effect, they call it. Yeah, and that's what I was trying to summarize just in a couple of slides in the middle of the presentation, is that tight control of sugar, and UKPDS, for all its flaws, is probably the best that shows this, that if you follow people for 20 years, the tight control that they had for 10 years of the trial has not long gone, but you do see reductions in myocardial infarction and cardiovascular death. Now, it's not the same degree of reduction that you get with good control of blood pressure or a decent dose of a statin, so it's not comparable, but it is there, and it's certainly not harmful. Yeah.
Thanks, Miles. I don't see any further hands raised. So just to wrap up this session by thanking you once again for this excellent talk on diabetes. I'm sure everyone agrees. And one last plea that if you haven't already joined SHARP, please consider doing so. And if you'd like a certificate of attendance, please email the SHARP office. You'll have the email address as we've sent you the links for this webinar. So thanks everyone once again, and have a good evening. Thank you.
Thanks again. Good night.
Good night.
Bye, John.